Yeah. Oh, okay, he's left that there. So I hear yesterday's recorded okay. I don't know if any of you listened to it, but that one didn't work, but obviously I was picking it up off that mic, so. Yep, that one works today. Forget it. Okay, I think we're ready to go. Okay, so yesterday I talked to you about autoimmune diseases, and it sort of makes sense that today we follow on with immunosuppression. This is what you need to know out of this particular lecture today. So you need to be able to outline how the immune system works, just basically understand an overview of it. Describe the central role of T cells in the adaptive immune system. Describe the importance of IL-2 in T cell activation, that is induction of T cell activation. IL-2 is extremely important. Outline why immunosuppressant therapy is needed. And describe in some detail the mechanisms of action of the different classes of different immunosuppressants. List the adverse effects of some of the immunosuppressant classes, and explain how dangerous drug interactions can arise with immunosuppressants. So there's sort of areas that you need to understand. So what is immunosuppression? Well, it's the partial or complete suppression of the immune response in an individual, either naturally as a result of disease or another condition, or artificially induced to help the survival of an organ after a transplant operation. And I suppose a lot of what we're going to talk to today is in the context of transplants. So why do we want to suppress the immune system? So, one, you might want to prevent or reduce rejection of an organ that's transplanted. And of course, we've got to overcome the normal suppression of the immune response. The normal appropriate immune response, we have to suppress that. And of course, as soon as you put a foreign antigen into a body or a foreign organ, you're going to get a lot of antigens being released that are going to be deemed as foreign and have to be eliminated, or at least the body wants to eliminate it. And things like kidney, liver, heart, etc. One I want to just pay attention to is bone marrow, and where you can get graft versus host disease. Whereas in a normal transplant, the host rejects the donor's organ, with GVH, what happens is the bone marrow, so that is the donor's cells, reject the host. And so the opposite happens. Not that we're going to talk about graft versus host today, but just to let you know. Treatment of autoimmune diseases, leading on from what we talked about yesterday. So you want to suppress an inappropriate immune response to self. An example of systemic lupus, SLE, systemic lupus erythematosus, rheumatoid arthritis, systemic sclerosis, etc., etc. And it's now becoming a lot more targeted. So the approach is more targeted. And we talked a bit about anti-TNF alpha and anti-IL-6 therapies, etc. yesterday. And a treatment of some resistant inflammatory diseases. So you want to sometimes suppress some inappropriate immune reactions to foreign antigens, except like we have, for example, in asthma, where you may be using inhaled corticosteroids to suppress that effect, that immune response. So there are a number of reasons why we want to suppress the immune system. So this is just a very basic overview of immune activity, which we talked about before. Non-activated, so this is normal steady state. Innate, and this is where you've got an antigen or injury, which leads to accumulation of inflammatory cells, release of cytokines, and then you get neutrophil killing bacteria, etc., macrophages mopping it all up. Or you've got the adaptive immune system, where you've got an antigen that is presented by antigen-presenting cells to T cells, and then you get proliferation of T cells and activation of B cells and other cells coming in, etc., and then you've got your adaptive immune response. We have T cell mediated or humoral immunity. So what about an overview of immunity with regard to transplants? Well, pretty much what I just talked about. You've got innate immune system, which is non-adaptive and broadly selective. It's activated immediately due to graft trauma, for example, and also due to reperfusion injury. And reperfusion injury is where an organ that's had no blood flow for a long time all of a sudden gets blood flow and gets oxygenated. And what happens is a massive release of oxygen radicals, so reactive oxygen species, and then that can then damage the vessels and damage the organs as well. And it involves dendritic cells, monocytes, macrophages, NK cells, neutrophils, chemical mediators, lots of things are involved in the system. Here's just a scanning EM showing a macrophage, just looks pretty. And you can see all the ruffles on the cell. And the adaptive immune system. So specific, learned, and remembered response to foreign antigens. It's dependent upon T and B cells and express specific receptors against graft antigens. Adaptive immune response activation occurs in two different phases. One is the induction phase, we talked about again this yesterday, where the antigen is presented to the T cell, and the effector phase, where the T cell and the B cells become activated, and that's both cell-mediated and humoral immunity. And of these adaptive immune responses, really, that T cell is the regulatory cell. It's all about the T cell. I work on B cells research-wise. Everyone tends to forget about the B cell because they all talk about T cells, but T cells in this case are very important. And T cell is a central player in adaptive immunity. First of all, T cell activation requires antigen recognition at this point here, so the antigen is released, and then the T cell, or the antigen is presented by the antigen presenting cell to the T cell. You then get clonal selection, so those T cells that express the right antigen are selected. You get IL-2 secretion, and you get clonal expansion. More and more of those T cells are made. This is the induction phase, and then T cells activate other immune cells and also activate themselves. And so this is the activation phase. And what's also really important is what happens at that antigen presenting site. So you've got T cell activation requires class 2 expression on MHC class 2 expression on the antigen presenting cell, and you need a T cell receptor with a CD3 component to that. You then need expression of CD4 or CD8 co-receptors, and you need co-stimulatory signals, something like B7 or CD28, to activate that T cell. And so then you get T cell differentiation. We're not going to go into a great deal of depth, just to say that once you've got T cell, IL-2 is being secreted and you get T cell expansion, you can then get a whole range of cytokines that are released to then differentiate that T cell into a lot of different phenotypes. And you can see here some of the different phenotypes, because we're not going to talk about detail of them. And each of these phenotypes then make their own cytokines, which have influences again on the immune response. And they have a whole range of functions, the different T cells. And some of these we'll talk about later, a big one being Th17, which is important, and I mentioned yesterday, important in fibrosis. So the interleukin-2 and interleukin-2 receptor are really crucial in this whole process. It's produced by activated T cells and it regulates T cell proliferation. Therefore, it's an autocrine growth factor made by the T cell to act on itself. The IL-2 receptor consists of 3 different subunits: IL-1/2 alpha, IL-1/2 beta, IL-2 receptor beta, and IL-2 receptor gamma. And IL receptor 2 alpha is also called CD25. And this is a biomarker that's often used because IL-2 receptor alpha, or CD25, is upregulated in many different conditions, autoimmune conditions, cancer, etc. So it's often used as a biomarker, particularly to look at the effect of treatment. And this just shows what the complex, the trimeric receptor, looks like. There's IL-2 binding to it. But IL-2 signaling is very complex. I'm not going to go into IL-2 signaling other than for you to know that it's a complicated system and involves lots of different components. But patients lacking the IL-2 receptor gamma, for example, have what they call severe combined immunodeficiency syndrome, or SCID. So effectively, they have no immune response. And this was highlighted by a film that came out in the, I think, 70s, or maybe 70s, 80s, called The Boy in the Plastic Bubble. And it was about the life of David Vetter. And David Vetter was a young kid in America who basically had SCID. And he had to live his whole life in a plastic bubble, where they had to autoclave food, or anything that went into him had to be sterilized before it went into him. And he eventually died at the age of 12. He got a bone marrow transplant from his sister and got Epstein-Barr virus from his sister. They didn't realize she had it. And he then died subsequently of Burkitt's lymphoma because he had no immune response against the virus, of course. And he ended up with the EBV-induced cancer, Burkitt's lymphoma. And IL-2 knockout mice also develop autoimmune diseases. And the reason for that is because Tregs require IL-2. And if they haven't got IL-2, then you've got no T regulatory cells. And it's the T regulatory cells that control the immune system. And so these guys then get autoimmune diseases. So IL-2 then is the main target of the immunosuppressant drugs. Okay, really important. IL-2 is the key target. So let's overview allograft rejection. Allograft is when something of the same species is put into another person. It's a complex T cell dependent process, and there's 4 phases in that process. Antigen presenting cells migrate into the area, usually into a lymph node, and antigen processing occurs. You then get priming or activation of those naive T cells by the antigen presenting cell. IL-2 driven T cell clonal expansion and differentiation. And then you get migration of the effector cells into the allograft itself, into that graft. You get your CD8 cells, your CD4 T cells, macrophages, B cells, etc. And this basically shows you what happens. So let we talk about a graft here. You've got a graft, and 2 things can happen. You can either get direct recognition. So what happens is that the antigen presenting cells come out of that graft. So it's the donor antigen presenting cell that presents self to a T cell from the host, and the T cell then goes off and destroys the graft. So you get cellular rejection. And this is CD4 and CD8 mediated toxicity. Or you can have an indirect recognition, and that is where antigens are released from that donor graft, and that is then presented by the host antigen presenting cell to the T cell, and the T cell goes off and activates B cells, and you get humoral rejection. So it's mainly antibody-mediated rejection. So direct recognition, indirect recognition by either cellular or humoral responses. So let's talk about now some of the different immunosuppressants and how they work. And we're going to talk about really drugs that prevent IL-2 driven T-cell clonal expansion. That's what we're talking about. And we're going to talk about calcineurin inhibitors such as cyclosporin and tacrolimus, and also glucocorticoids. And then we're going to talk about mTOR inhibitors such as sirolimus and everolimus, and mycophenolate and azathioprine. So let's first of all talk about the calcineurin inhibitors. So we've got cyclosporin, which really, this is just three ways of saying cyclosporin. You can see it as cyclosporin or CSA, same drug. And we have tacrolimus as another form of the same type of inhibitor. The structures of cyclosporin on the left, and on the right, tacrolimus. Not that you have to learn those structures, so don't worry about that. And these drugs actually revolutionized transplant surgery. So first of all, cyclosporin A. It's a cyclic peptide of fungal origin. It's really small, it's only 11 amino acids, but it can be given orally, but it's very poorly absorbed, so it's usually used intravenously. Its half-life is about 24 hours, and it's metabolized in the liver, and it's then excreted in the bile. Whereas tacrolimus, it's also fungal, and it's works by a very similar mechanism, although it does have a very different receptor. And it's a lot more potent than cyclosporin A, in fact up to maybe 100-fold more potent. So you can imagine it's a better drug. It can be applied by orally, intravenously, or topical administration. The problem is it's got a shorter half-life of only about 7 hours, so it means you've got to take the drug 3 times a day. And its metabolism is exactly the same as cyclosporin. However, it has different side effects and different toxicities than cyclosporin A. And these two guys on the right here, Sir Roy Kahn and Thomas Stull, they revolutionized liver transplant surgery. In fact, they were the first people to do liver transplants, and they also played a big role in the development of the different immunosuppressive drugs. So how do cyclosporin A and tacrolimus work? So they're the most effective immunosuppressant drugs. But what they do is they target intracellular signaling pathways. And what they do is they inhibit the T-cell receptor signaling by blocking activation of the IL-2 gene transcription. Calcineurin itself is actually a calcium-dependent serine-threonine phosphatase. And it works through here. So here on the right, you've got your T-cell receptor through the pathway, and here you can see where calcineurin forms. So it's important. And its main function is to dephosphorylate NFAT, which is nuclear factor associated with T cells. And this dephosphorylation of NFAT allows this transcription factor to go into the nucleus where it's important in transcription. So if you can block this at this level, then you're going to block whole transcription and basically IL-2 production. So effectively, NFAT dephosphorylation is what's required, and it also promotes NFAT to nucleus. So this is what calcineurin does, and it upregulates gene transcription. So by blocking that, we stop that. And we can also, to improve the uptake of the calcineurin inhibitor, we can use immunophilin, which is a chaperone protein, and that actually improves the inhibitors. So what about some of the side effects of these calcineurin inhibitors? So the calcineurin inhibitors, they markedly decrease allograft rejection, but they're associated with increase of chronic transplant dysfunction due to immunological and non-immunological effects. In other words, they reduce the immune response, but of course, as soon as you reduce the immune response, you're going to have side effects. You know, it's good to have it because we need it, but you're going to have problems as well. Inducing immune suppression means you're going to get more infections, bacterial, fungal, viral, etc., and you're going to get more malignancies. And there's an association with these inhibitors with squamous cell carcinoma. 60 times more likely to get squamous cell carcinomas if you're on these inhibitors. And likewise, human papillomavirus, UV, etc., can be more potent in the presence of these inhibitors to lead to specific cancers. It's also lymphoproliferative, particularly in the presence of Epstein-Barr virus, and these can then lead to the development of different cancers as well, blood-borne cancers, T and B cell cancers, leukemias, etc. It's got nephrotoxicity, so therefore it's toxic to the kidney, both in the short and the long term. It can induce hypertension because it interacts with the renal sodium transporters and leading to high blood pressure. You can get increased sugars in the blood, hyperglycemia, especially in response to tacrolimus, although they don't know the exact mechanism, although they think it's related to reduction of insulin. And these three in particular can lead to graft failure and cardiovascular disease. Dyslipidemia, caused by cyclosporin in particular, leads to increased amounts of lipids in the blood. You can get neurotoxicity, and you can get hirsutism and gingival hyperplasia. And if you don't know what hirsutism is, like I didn't when I first saw this, it's unwanted hair growth. So you get hair growing in places you don't want it and not meant to be there. And gingival hyperplasia, you can clearly see here that the gums are hyperplastic and they're very much swollen and they're overgrown. And you know, these are nasty, and it's the cyclosporin that mainly does this last two. So you can see why tacrolimus is generally considered the calcineurin inhibitor of choice. So what about the antiproliferatives? So these include antimetabolites and also the mTOR inhibitors. So antiproliferative, effectively, it's the prevention of the mitotic, or the ability to proliferate, response to IL-2 stimulation. And it can work through the antimetabolites, mycophenolate, azathioprine, or the mTOR inhibitors. So first of all, mycophenolate. It's a fungal-derived prodrug. It occurs as mycophenolate amophytyl, and that then gets metabolized in the body to mycophenolitic acid, and it inhibits the inosine monophosphate dehydrogenase. And this particular enzyme is required for GMP synthesis. This is de novo, in-body GMP synthesis. And that's really important because both B and T cells depend on de novo GMP synthesis because they lack the salvage pathway for guanine recovery. So they can't use breakdown of RNA or DNA to recover the guanine that's needed. So it needs to have de novo GMP. There's specific inhibition of RNA and DNA synthesis occurring because of it, of this drug, and also any other pathways which require GMP or GTP. It's well absorbed, so it's given orally, and it's usually given daily. And it's impaired by antacids, so magnesium and aluminium hydroxides, for example, will inhibit its absorption across the gut. It does have side effects. It doesn't affect the kidneys, but it does affect the gastrointestinal tract, where you end up with nausea, vomiting, diarrhea. It can cause myelosuppression, that is, the myeloid cells in the bone marrow don't replicate, so you don't get your macrophages and your neutrophils and your blood cells, etc., your red blood cells. But it's not as bad as azathioprine, and it can lead, of course, to infections and malignancies. So this is the pathway, GTP synthesis. So the salvage pathway, which is absent in B and T cells, which can get guanine from the body, it can't do that. So it requires this de novo synthesis pathway, where it needs inosine monophosphate, which then gets translated into guanosine monophosphate by the inosine monophosphate dehydrogenase, which then leads to GTP, DNA, and RNA production. And it's the mycophenolate which inhibits the dehydrogenase. So this is the point where it blocks it, and therefore you can't get guanosine monophosphate, and everything gets stopped from there down. So mycophenolate's effects, though, are relatively lymphocyte specific. So azathioprine, this just shows the structure of it with some of its analogues. So Roy Cullen was really important in the development of azathioprine. He wasn't the only person, of course, but he helped in the development of it, as well as being a surgeon. And of course, it makes sense that surgeons will be really important if they're going to be transplant surgeons, that they want to improve the drugs for immunosuppression. It's the dominant immunosuppressant historically, okay, along with glucocorticoids. It was one of the first ones used. Except it's now replaced by mycophenolate, and the reason is that it's much more effective, but unfortunately it's also 15 times more expensive. It's a prodrug, and it's metabolized to 6-mercaptopurine. And this is the pathway. So azathioprine here is converted to 6-methylpurine, and then 6-thioguanosine monophosphate. And this is actually a purine analog, so this will not allow DNA synthesis. Okay? So it blocks DNA synthesis. So it interferes with DNA replication, and it mainly affects T and B cell proliferation, especially T cell clonal expansion. But the effects are not lymphocyte specific, so it does have effects on other cells we don't want it to have an effect on. And so as such, it has adverse effects, and these are very common. So it's anti-proliferative and affects rapidly dividing cells. So cells that we want to have rapidly dividing, it kills off. You can also imagine azathioprine is also used as a chemotherapeutic agent, okay, in different doses. And the anti-proliferative effects that it have that we don't want is effects on the gut, because we end up with nausea and vomiting, and we have mucosal ulceration. The bone marrow, myelosuppression, as I mentioned before, and on hair follicles, so it causes us to lose our hair. It does not affect the kidneys, unlike the calcineurin inhibitors, but it is mildly hepatotoxic, so it affects the liver, and it also affects, so you get hepatitis and you get cholestasis. And cholestasis is just the bile that's produced in the gallbladder doesn't get transported to the duodenum, so you can't get breakdown of fats. It does have drug interactions with other purine analogues, such as allopurinol, which is used for the treatment of gout, and allopurinol blocks uric acid formation. And it can interact. So genetic polymorphisms can occur in this thiopurine S-methyltransferase. And what it does is if this cannot be active, it can't break down azathioprine properly. And what happens then is you get relative different levels of azathioprine, and it can cause really severe toxicity in about 1 in 300 patients. So what about sirolimus, which is a rapamycin? Rapamycin's original drug, which is the trade name, is then sirolimus, and then everolimus, which is a derivative of sirolimus. So these are fungal macrolides. They also associate with tacrolimus, but they're not inhibitors of calcineurin. Okay, they're not calcineurin inhibitors. What they are, though, is they inhibit the mTOR pathway by decreasing the translation of one of the important molecules in the pathway, S6 kinase. So effectively then they are mTOR inhibitors, and they're the most commonly used mTOR inhibitors. So just showing the mTOR. So T cell activation still occurs, but protein translation decreases. So it inhibits IL-2 induced cell cycle progression to prevent T cell clonal expansion. So T cells can't proliferate. Everolimus has got a half-life of 30 hours, sirolimus has a half-life of 60 hours. But they have side effects. Again, they don't affect the kidney, and they do have reduced risk of malignancy, which is good, but they're dose-dependent. You get a dose-dependent increase in cholesterol and triglycerides, so that has to be taken into consideration. And it also can still cause myelosuppression. So now about the glucocorticoids. Well, this is just a few of them. There's so many different glucocorticoids, but probably the most well-known is prednisolone, hydrocortisone, dexamethasone, etc. So these are used for induction therapy to prevent or treat acute rejection. Okay, and usually the drug of choice is methylprednisolone. They're also used in maintenance therapy to prevent or treat chronic rejection. So this time they use the prednisolone. And immunosuppressive effects occur in two ways. Either have direct effects on the immune system, or they have anti-inflammatory effects. So basically affect that effector phase. And they have many target cells. So it involves T cells, B cells, innate immune cells, macrophages, etc., endothelial cells, etc. And this just shows you a picture here on the right, transmission EM of a macrophage at the top, which has been coloured in, and also neutrophil at the bottom. And it has effect on T cells by decreasing IL-2 production and clonal expansion. And as you can imagine, because it does so many different things, it has really, really broad applications. So glucocorticoids are used for lots of things. So what about biologics? And as you can imagine by this picture, we're talking about antibodies. So we can have immunodepleting antibodies. These are quick and potent immunosuppressants. You can have polyclonal antibodies. So they actually affect lots of different proteins on the surface of T cells. Okay, well, B cells, but mainly T cells, and thymocytes. And the most common one that's used is thymoglobulin. It's a rabbit anti-thymocyte globulin, and it's used to deplete T cells mainly. It targets many different T cell epitopes, and it depletes T cells, and it has a profound immunosuppressive effect. And you can also have monoclonal antibodies. So these are directed specifically to a particular antigen, one monoantigen. An example of this is basiliximab. This targets the alpha subunit of the IL-2 receptor, in particular IL-2 receptor alpha, or your CD25. And CD25, of course, is only expressed on activated T cells, so it's a more targeted T cell therapy. And it's the antibody of choice to prevent acute rejection. And it reduces rejection rates by about a third. And another drug is rituximab. Rituximab is a anti-CD20 antibody. So CD20 is a molecule expressed on the surface of all mature B cells. And so therefore it's used to get rid of B cells in any antibody-mediated or to get rid of antibody-mediated or humoral rejection. So how do we go about preventing acute rejection? Well, the typical treatment is we use at pre-transplant, that is on day 0, we have high-dose methylprednisolone and basiliximab. We then use a thymoglobulin given instead of the this is just saying that thymoglobulin can be given instead of the basiliximab if there's high immunological risk of acute rejection. Just showing here that when you have a kidney transplant, this is a side issue, if you have a kidney transplant, I didn't realize this, that the transplant's actually put in as well as keeping your previous kidneys. So they don't remove the damaged or injured kidneys. Because depending, of course, unless you only have one, then you'll still get some function out of these kidneys. So literally it's just an additive, a third kidney that's actually transplanted in. And they don't just transplant the kidney, they transplant the ureter as well. So post-transplant, they then give you the calcineurin inhibitor, tacrolimus. They give you an anti-proliferative, such as mycophenolate. They can give azathioprine. They don't do it very often. It's only if you can't tolerate mycophenolate. And you give high-dose prednisolone. And the dose is initially really high, and then it's lowered over the next sort of 3 months. And then at day 4, they give a second dose of basiliximab. So you can see how actually powerful these, the anti-inflammatory, immunogenic drugs are. I mean, there's so many of them that they're given to these patients that their immune system is just going to be absolutely wiped out. So you can see that these guys are going to really have to be very, very careful for the rest of their life. And so, you'll often know people who have had transplants, and these are ones that, of course, need high dose of immunosuppressants. If you've got a transplant from a closer relative, for example, then the degree of immunosuppression is not as great as if it's someone from someone that's not related. But these guys are extremely, extremely immunosuppressed, and they have to stay immunosuppressed. And then to maintain the immunosuppression, this is really important. There's a very narrow therapeutic window. So we come back to our old pharmacodynamic curve here, where we have our desired effects and our toxicity, and we have a really narrow window of a therapeutic range that we get effect without toxicity. And therefore it's really important that these guys are monitored regularly, essential and often for their drug levels. And the therapeutic levels are necessary to keep that efficacy, so they must keep those levels high. But of course, the toxicities occur within the blood at levels very similar to the concentrations of the therapeutic levels. So you must keep that balance absolutely spot on. And there's very large inter-individual variation. So again, you can't, because one patient has a particular response, doesn't mean another's going to be the same. So you must monitor regularly. It's also really important to know any potential drug-drug interactions and any other specific toxicities. And therapeutic strategy is really, if you can combine drugs of different classes, that's really an advantage, because by doing that we can potentially lower the dose. If we get a synergistic therapeutic effect, we can have lower doses of the drugs. But we also have different side effects. So what about drug-drug interactions? Well, there are many of them, and they're frequent and they're very important. We're not going to talk about specifically the different interactions, just to really warn you and let you know that there are, and they must be considered. So they're important because immunosuppressant efficacy and toxicity are drug concentration dependent. They're especially important for efficacy. Frequent transplant patients almost always take other drugs because they have other comorbidities. Hypertension, hyperlipidemia, cardiovascular disease, type 2 diabetes, etc., etc. And many drug interactions occur at the level of absorption and of metabolism. So you've got to take everything into consideration. So if patients are on any of these drugs, you must find out what other drugs, immunosuppressant drugs, you must find out what other drugs they're on to work out whether there's going to be any interaction that goes on. So just want you to remember then that you can't under immunosuppress, otherwise you're going to get rejection. But if you're over immunosuppressed, you're going to get lots of things that you don't want, such as infections, malignancies, cardiovascular disease, chronic kidney disease, and the list just goes on and on and on. So this is just some further reading if you want to read up a little bit more on some of these drugs and the relevance particularly to autoimmune diseases as well, as I talked about yesterday. So that's it. So if anyone has any questions, or otherwise you can always pop down and see me at the end of the lecture now. All right, thanks then. Yeah. No worries. Oh, that's why I was putting it upside down. Ta-da. Bye.
Quick questions.
Yeah.
Incredible lecture, by the way. Fascinating that they don't actually take out the other kidneys. You just put
Yeah, I didn't know that, so I thought I just said
just
it.
like, wow.
Yeah, I never thought of that. Yeah.
So transplant patients, are they on a dose of immunosuppressants for their entire life?
Their whole life, absolutely.
So that if you have a transplant, you're just immunosuppressed for the rest of your life.
Absolutely. So, you know, a lot of people that have transplants, and I said, I sort of, the catch there is the degree of immunosuppression depends on the degree of dissimilarity when you've actually had, you know, from the transplant. Right. And so, you know, some patients don't need so much because if they've got it from a close relative that's got a match, but if they don't, they're on really high doses and, they have to be very, very careful whatever they do.
Right. So it's not just immediately after the surgery,
it's forever.
Life.
Forever.
Because
your body is going to try and reject itself.
Yeah, exactly. Yeah.
No, reject the foreign tissue.
And
often, see you later, no worries. Often they do, and so eventually, you know, a lot of people that go and have transplants. Kidney is probably the most common one.
Yeah.
It's most common to have it from a non-relative,
Yeah.
you know,
From like an organ bank or something.
you know, and it probably survives a lot better than, say, a liver does, but but eventually it can reject, and so a lot of people who have a kidney transplant will have to have a second kidney transplant
Really?
down the track. Yeah,
Wow.
yeah. But it also depends, if they do the right thing
Yeah.
and they stick with their drugs and do it, but people don't often, and then you get rejection.
It's just like, yeah, what are we even doing?
Yeah, it's pretty. I mean, you know, transplants are pretty heavy stuff.
Oh, yeah.
Yeah.
I mean, who invented that? Hey, who
Oh, you
let's
came
open
up.
this person
Yeah,
up.
why would you?
Stick a kidney in there and just hope for the best.
Yeah, and then stick some fungal proteins in and see how it.
It's such a weird
It's
concept.
a lot of things that, you know. I look at a television and think, how in the hell did someone just make that and work it out? It comes through evolution over a long period of time.
Yeah, I mean,
you
I
know.
go out to the bush for like a walk in the park or something, and I think we made Wi-Fi out of all of this.
Yeah, I know, it's incredible, isn't it? Yeah, sometimes it's but you know, it's step by step, and this is where, you know, a lot of research has gone into a lot of this
Yeah, are
stuff.
we still putting a lot of money into research for better immunosuppression?
Oh, absolutely, because of the side effects.
Yeah,
You know, if we can get an immunosuppressant which targets just the cells we want it to target without causing all these other nasties, then that's ideal. So, look, and it's getting more specific. So, you know, some of the ones I talked to you, metabolites and antiproliferatives, that really targets a broad thing. But when you start using like the mTOR inhibitors, we can specifically target pathways.
Antigen specific.
Possibly, but we don't know the antigens,
Yeah, right.
you know, so then you'd have to identify the antigen. Look, it'll probably come one day that we can identify the specific antigens and target those somehow, but at the moment it's more of a broad acting, but they're getting closer and closer, you know, more and more specific to just targeting the cells that we want.
Reducing the body-wide effects of immunosuppression.
Well, it is, yes. So, you know, for example, the mTOR inhibitors they showed, you know, they don't cause so much cancer, they don't have a lot of toxicities, they still have some issues, you know, myelosuppression and increase in blood lipid, etc., but they don't have a lot of the other ones. So, you know, if that works, they're far better. The problem is the prices of mTOR inhibitors. Huge.
Yeah.
So people sometimes just, you know, either they don't have access to them or can't afford it. And, you know, in some countries, you know, I think in Australia, it's on their PBS, so it's fine. But if you're in places where they don't have that, you can't afford these specific inhibitors. You know, and so there you have to use the broad-acting ones, and they come with more
Poor
problems.
patient outcomes, yeah. Which was the one that, was it 60 times higher likelihood to get squamous cell?
Squamous cell carcinoma. Yeah, which one was that? I can't remember which one of those immunosuppressants was, but yeah. Yeah, and it's interesting that it's specific types of diseases which seem to come up. You know, a lot of these I talked about saying the mechanism of, they don't really understand the mechanism.
They just know what happened.
They know that, you know, this is one of the mechanisms. And it's one thing we're going to talk about a little bit on Thursday. I think I give some lectures on tissue repair fibrosis. You know, a lot of these drugs that we say, oh, it works through this mechanism. It's a lot of rubbish. Yeah, yes, it might work partly through that, but
There's
it does.
so many other things going on.
And it's a lot of drugs we don't know until it's been given for 10 years that we start seeing all the other things it can do. So good and often bad. Yeah.
That's just incredible how it can, that particular type of cancer, squamous cell carcinoma.
Yeah. Why that one? I don't know. I didn't. I looked at it and I thought, should I look? I didn't look up the reasoning behind it, but.
That would suggest, right, that our immune system plays a pretty important role in suppression of squamous cell carcinoma if it arises when the immune system is suppressed.
Yeah, well, all cancers, but why squamous? Well, one of the reasons could be, so for example, if you're on an immunosuppressant, you have to keep out of light.
Seriously?
Okay, I'm talking about sunlight, because we're more susceptible to UV, and I sort of mentioned that. And squames, if you look at skin, is one of the highly responsive to UV light. You know, we get other things like basal cell carcinoma, which is not so important, but squamous cell carcinoma and melanoma, of course. Although they didn't say there was an increased risk of melanoma, but just squamous cell carcinoma. So there'll be something in the pathway of squamous cell carcinoma which is affected by these drugs. I don't know what it is. Yeah, I mean, I don't know. Maybe they know more about it. Chances are, probably don't. Yeah.
Do we claim that we know a lot more than we actually do in reality?
Well, we claim we do.
Yeah.
And so this is, you know, there's a drug that we're going to be talking about with regard to fibrosis called pirfenidone. And this is sort of thought to work through blocking a highly profibrotic mediator called transforming growth factor beta. And it says it blocks this pathway and that's how it works. Well, I do a lot of research and on fibrosis, and we do a lot of work with pirfenidone. We don't find it had any effect on TGFB. Another drug, which is a tyrosine kinase inhibitor, does have an effect on TGFB, and yet it's not meant to.
Yeah, right.
Now, it could be secondary effects, but, we don't know. We claim things, but we don't know a lot.
It's so variable, isn't it? I mean, when you look at the metabolic pathways of the body, it's just there's so much going on.
Oh, yeah, absolutely. Absolutely. Well, you throw, I think I'm probably going to put one up actually in one of my next lectures, and just show, all the signalling pathways. And that's probably just a minutiae of what's really known. It's just blows your mind, sort of thing. Yeah, it is.
How much is going on at any given time.
And how everything affects everything else. And that's the thing. You block one thing and you get an outcome, but it affects everything else. And like I said, some good, but mainly bad. So.
Very, very thorough, comprehensive lecture.
All right, no worries. Okay.